Okay, I'm gonna make this quick to get this out before the TA session, which is in a little over 3 hours. First of all, shout out to P and Joe for going over everything, pulling up the slides and making sure everything goes in depth. Oh, they also split this into like each part of the leg or lower extremity, from like thigh to leg to knee, foot, hip, whatever, to kind of organize this. I'm gonna write in blue because all this stuff I already have written in red, which I can send out. Sorry for the bad handwriting. Are all stuff that she's asked before. So if they are going to repeat stuff, that would be nice. The stuff that I couldn't fit in, I added all the way at the end as like side notes. So here, again, sorry for the handwriting, but I'll like reread all this stuff. Okay. For the lower limb, we have 3 compartments for the thigh, 3 for the leg. For the thigh, it's anterior, medial, posterior. For the leg, it's anterior, lateral, posterior. So that's like the first main difference. In the thigh, anteriorly, it's nice because the nerve and arteries are the same. Posteriorly, for the medial compartment, which are like your adductors, it's obturator, nerve, and artery. For the posterior, the back, this is going to be sciatic nerve. But for the artery, it's deep femoral artery. So deep and profundo just means deep. This is going to be like your hamstrings, because we're talking about back of the thigh. Medial thigh, we're talking about your adductors. Anterior thigh, we're talking about your quads. Now for the leg, this sciatic nerve is going to, when it comes down the back of the leg, after the pop fossa or in the pop fossa, it's going to split into tibial and common fibular. Everything above the pop fossa, it's still sciatic nerve, but it has like a tibial portion of the sciatic nerve and a common fibular portion of the sciatic nerve. The tibial portion of the sciatic nerve is going to do most of the hamstrings. The common fibular portion will do the short head of the biceps femoris, but it's still sciatic nerve. So if they ask what innervates the hamstrings, it's sciatic nerve. But if you want to get specific, it's either tibial or common fibular portion of that. But after the pop fossa or in the pop fossa, it becomes tibial and common fibular. And then common fibular is going to split into superficial fibular and deep fibular. Deep fib is going to do the anterior compartment. Superficial is going to do the lateral compartment. And tibial is going to do the posterior compartment, which is the largest compartment. Lateral compartment are going to be like your fibularis longus and brevis. Posterior compartment is going to be like the superficial stuff, which is like your gastrosoleus plantaris. The deep posterior stuff, which is your tibialis posterior, your flexor hallucis longus, flexor digitorum longus, popliteus, and then the anterior stuff is going to be your tibialis anterior, extensor digitorum longus, extensor hallucis longus, and the fibularis tertius. So that does nerve supply. We said deep tibial, superficial. For arteries, anterior, posterior is nice because it's just anterior tibial, posterior tibial. The lateral does not have its own arterial supply, but it gets perforating branches from both the anterior and posterior arteries. So from anterior, it gets anterior tibial arteries, perforating branches. And then from posterior, it gets fibular artery, which is a branch of posterior tibial artery. So it gets contributions from both anterior and posterior. And that should be it for that. Once we get to like the leg stuff, which is on page like 8, this kind of goes over all that stuff again. So hopefully that like hammers that concept in. Okay, stuff that, oh wait, let me go over the red stuff. One of the questions that she's had before is if you get anterior compartment syndrome, what do you lose? And from the options, it was the dorsalis pedis pulse, because anterior tibial artery, as it goes down in the, once you get past the inferior extensor retinaculum, so like in the foot, the lower part, this becomes dorsalis pedis artery. So if you have anterior compartment syndrome, and your anterior tibial artery is gone, which obviously wasn't an option here, then the artery that comes later is also going to be gone. The other question was what supplies the lateral compartment of the leg, and it was the perforating branches of fibular and anterior tibial. Okay. Structures that leave the greater sciatic and less sciatic foramina, the piriformis, relationship to arteries, veins, nerves, whatever. So for the piriformis, that's going to be in your greater sciatic foramen. The only thing that goes above it is nice because it's called superior gluteal vessel, so artery, vein, and nerve. This is the only thing in the greater sciatic foramen that goes superior to the piriformis. Inferior is going to go inferior, but so will everything else. So sciatic nerve, the posterior cutaneous nerve of thigh, sometimes is also called posterior femoral cutaneous. When you say femoral and thigh, it's the same thing. And then nerve to obturator internus, quadratus femoris, pudendal, internal pudendal vessels, which are artery and vein. For the pudendal, the nerve is just pudendal. The vessels are internal pudendal, artery and vein. So all of these go through greater sciatic foramen. Some of the questions she's asked before is which of these does not go through the greater sciatic foramen, and one of them was medial femoral cutaneous artery, which obviously you don't see on this list, and the other one's the obturator internus muscle, which does not. The nerve does, but not the muscle. Another thing is for the obturator internus, so if you remember GO GQ, the obturator internus nerve also supplies the gemellus superior muscle, whereas the quadratus quadratus femoris nerve supplies the inferior gemellus. So if you remember, the top G is superior, bottom's inferior, and then it goes like this. So she could go like, what supplies the gemellus inferior? It's the quadratus femoris nerve. What supplies gemellus superior? Obturator internus nerve. The other thing she's asked before was like which of these is not true, and it's not true that the obturator internus and externus are innervated by the obturator nerve. The externus is, but not the internus, because internus has its own nerve. And then the last thing is knowing that the pin structures are the ones that like loop around, go through greater and then out of lesser, and that's your PIN. If you remember, this and this are nerves, so it's pudendal nerve. And the last one is nerve to obturator internus. The way I remember it's internus, not externus, is because there's an I in pin, so it's I internus. And then the I, these are not nerves, these are your vessels. So internal pudendal artery and vein. So your pin structures. Okay, for the femoral triangle, your lateral border is your sartorius, your medial border is your adductor longus, and then your superior border is your inguinal ligament. The apex of the triangle is going to be right here. So this is going to be the apex right here. The floor muscles, the main ones are iliopsoas and pectineus. Iliopsoas is going to be more of the lateral floor. And then pectineus is going to be more of the medial floor. So pectineus, when you think about the floor of the vein and artery, under it is pectineus. But when you go laterally, under the nerve, it's iliopsoas. Another question she's asked about the pectineus before is which of these muscles gets like dual nerve supply or dual innervation. And because of the route of the pectineus, it like kind of starts here where like your adductors start, but it's an anterior compartment muscle. So it actually gets both obturator and femoral nerve innervations. The other thing they've asked before is for the adductor longus, know that it's the horseback rider muscle because it's the adductor. That's what like keeps you on the horse. Another one was like when you're doing surgery, you like put your finger into like the most medial aspect of the femoral triangle or whatever, and you feel a sharp edge, and that's the lacunar ligament. Another one is knowing that the femoral nerve is outside the femoral sheath. So when you go medial to lateral, it's van. So medial to lateral is van. If you're going to go lateral to medial, you can do navel. So make sure you know which way you're going from. But medially to laterally, something they've asked is if you have a femoral hernia. So the hernia is going to be in this space right here, this open space, which is the femoral canal. They ask what's the first structure lateral to it, and it's femoral vein. Because this is the medial side, so lateral to it, first thing's going to be the vein. The other thing they love to ask is which of these is not in the sheath, and it's the femoral nerve. And then if they ask for canalization, if you're trying to access the femoral vein, you access it through the saphenous opening, because the great saphenous vein is going to drain into the femoral vein, and there's like a saphenous opening there. That's what I could remember. Something else they've asked is which of these is in the muscular lacunae, so not the stuff here, like the vein and the artery, the lymphatics, the lymph nodes, the cloquet, which they've also asked. So that's all vascular. I think of vascular, I think of vein, artery. The only nerve you have there is the femoral branch of the genitofemoral nerve. So remember, the genitofemoral nerve is the one that goes like anterior to the psoas. So imagine you're like psoas right here. You have a nerve that goes like anterior to it, and then it has a genital branch, so you go to your genitals, and then a femoral branch. That's not the femoral nerve, it's just the femoral branch of the genitofemoral nerve. So that also like goes in here. But the one that goes in the muscular lacunae is the LFC, lateral femoral cutaneous. When you're talking about nerve, when we say LFC for the nerve, it's cutaneous. When we say LFC for the artery, it's circumflex. And then like we said, the floor of it is going to be the iliopsoas, whereas on the vascular side, the floor is going to be more pectineous. And then obviously the main nerve, which is the femoral nerve. So yeah, the key thing is just know if you're going laterally to medially or medially to laterally. I like going medial to lateral, just say van. But as long as you know that the lymphatics and the femoral canal are the most medial. Okay, boundaries and contents of the subsartorial canal. So where we said the apex is right here is where the femoral triangle ends. If you keep going down, now you're going under the sartorius. So under the sartorius, a submarine goes underwater. So under sartorius is going to be subsartorial canal. Also called adductor canal, Hunter's canal. I don't know why everything has a million names. But this has boundaries. So under it, you're going to have your vastus muscles. So you have your vastus lateralis, intermedius, and then medialis. This is like a commonly tested thing because the lateral border is actually the vastus medialis. So laterally to this, like coming down eventually, is going to be vastus medialis, which is weird because it's a lateral border, but it's medial. Behind it, so posterior to it, you're going to have your adductor longus and magnus. And then, obviously, if this is a subsartorial canal, the roof has to be the sartorius. So, in the subsartorial canal, you will have your femoral artery and vein, and then you'll have the saphenous nerve, which is a branch from the femoral nerve. So, branch of femoral nerve. And you'll have a nerve to the vastus medialis. All of these go through the adductor canal, but not the hiatus. So in the hiatus, the only things that go through are the vessels, the femoral artery and vein, because eventually they're going to become the popliteal artery and vein. No nerves. So if they ask which of these goes through the canal but not the hiatus, you can either say saphenous nerve or nerve to vastus medialis. I think the one they've asked before is the nerve to vastus medialis. I think for medial femoral circumflex, Oh wait, sorry. The reason I have that there is for when they ask which nerve travels with the great saphenous vein, it depends on if they're asking in the leg, like medial leg or medial thigh. If they're asking in the medial leg, it's the saphenous nerve. So travels with great saphenous vein in leg is saphenous nerve. In thigh, it's the medial femoral cutaneous nerve. It can be the saphenous nerve because the saphenous nerve went through the canal and then it branched out before the hiatus. So it doesn't make sense that it travels with the great saphenous vein, which is medial. So medial femoral cutaneous, which does like sensation to this medial area, goes with the great saphenous vein in the thigh. But once you go down to the leg, it's the saphenous nerve. And then femoral becomes popliteal in the adductor hiatus, which is an opening in the adductor magnus. Okay. The muscles that span two joints. So rectus femoris, this is key because it's the only quad that spans two joints. Your other quads, which are your vastus lateralis, intermedius, and medialis, do not span two joints because they start at the femur, either here or here or here, and then they go down, go to the tendon, whereas the rectus femoris starts at the AIIS. So rectus femoris starts at the AIIS. They also asked the question about something with like a patient, you have damage to the AIIS, what muscle is impacted? It would be rectus femoris. Sartorius and tensor fascia lata actually originate at the ASIS, not AIIS. What else? These three muscles right here are the ones that attach to pes anserinus, which is all the way on like the superior medial tibia. So it makes sense they cross hip and knee joint because the sartorius is starting at the ASIS. The gracilis and semitendinosus are starting either at the pubis, like the gracilis, or the ischium, like the semitendinosus, because it's a hamstring. So they all start in like the pelvis area, and then they go down all the way to the knee. So they cross two joints. And then all the hamstrings do as well. So semimembranosus and biceps femoris, long head. Only long head because short head starts on the femur, not ischium. And then if you remember the other thing we said, the long head gets sciatic nerve, but tibial portion of sciatic nerve, whereas the short head gets sciatic as well, but common fibular portion of sciatic. Okay, and then the reason tensor fascia lata extends is because it attaches to the IT band, and the IT band is the one that goes all the way down to Gerdy's tubercle, which is like superior lateral tibia. And then the ones that cross the knee and ankle, it's just gastro, but then remember plantaris also assists gastro and plantar flexion. But remember, not soleus, so that's important. Because soleus starts in the leg, does not start in the knee. Okay. Muscles acting on the hip joint. Oh wait, sorry, I missed something. Oh yeah, we had a question before that said which nerve innervates the tensor fascia lata, and it's the superior gluteal nerve. Did I miss anything else? No, okay. Muscles acting on the hip joint. So the main flexor is going to be iliopsoas. Main extensor is going to be the gluteus maximus. So if they tell you someone is sitting down and they're standing up now, so you're trying to extend, which muscle is involved? Gluteus maximus. If there's a weakness in standing up from a sitting position, your gluteus maximus is injured. So if they ask what nerve, it's your inferior gluteal nerve. The other thing she loves to ask is like which of these muscles are antagonists. So these two muscles would be antagonists because one is a powerful flexor, the other is a powerful extensor. Adduction is going to be all your adductors. So adductor, adductor, adductor. Obturator externus will do some abduction as well. Gracilis is the main abductor. Adductor. Abduction is going to be your gluteus medius and minimus. And if you remember, this is the part where these are the two muscles where if you have the Trendelenburg gait, the opposite hip drops. So if you have a right superior gluteal nerve injury, left hip will drop. So you'll have a weak gluteus medius and minimus. And then your lateral rotators are your P, go, Q. And we went over some of the nerve innervation in the previous stuff. Okay, action of adductor magnus. So adductor magnus has an adductor portion and a hamstring portion. So the adductor portion is going to adduct the thigh. Because it's the adductor part is a little anterior, it'll do some flexion as well, but it's more of an extensor because that's the hamstring portion of the thigh. In a femoral condyle fracture, the popliteal artery is at risk. The other thing they love to ask about the popliteal artery is that it is the deepest in the pop fossa, but because when you're looking at the pop fossa, you're looking at it from the back. If something is deep from the back, that means it's the most anterior of the vessels. For the cruciate and trochanteric anastomosis, what she asked for this was, out of all of these that do both anastomoses, they are all branches of what? So she wanted you to know that this, like superior gluteal, is a branch of internal iliac and inferior gluteal. Know that like the perforating were branches of deep femoral. So that's what she asked. I feel like if you're going to ask something else about this, it's going to be like the difference between them. So trochanteric is going to be a little higher or more superior. Cruciate is going to be more inferior. So if you're looking at the arteries involved, this will have superior gluteal, but as you go down, it loses it. So there's no superior gluteal here, but as you go down, you get the perforating for the deep femoral. The branches themselves also drop. So you go from ascending lateral to trans. So instead of ascending lateral, you get the lower one, which is the transverse lateral and medial. And then here you get inferior gluteal, but here it's like descending inferior gluteal. So everything kind of drops. So I think they'll either ask for all of the following are branches that are involved in the anastomoses, or they can just ask like slight differences between them. Okay, for the hamstrings, what they've asked before is if you get a fracture of the femur at the midshaft, what do you lose? And it's blood supply to the hamstrings, because your hamstrings get blood supply from the deep femoral perforating arteries. Because remember, we said that's what goes to the posterior compartment of the thigh. And then you remember the deep femoral arteries will pierce the adductor magnus. The hamstring muscles themselves are semitendinosus, membranosus, and biceps femoris, which has a long head and a short head. However, you also have the hamstring portion of adductor magnus, so obviously not the adductor portion. We know that your hammies start at the ischial tuberosity, so ischial tuberosity, ischial tuberosity, ischial tuberosity, ischial tuberosity. The different one is the short head of the biceps femoris, because remember we said it doesn't start at the ischial tuberosity. It starts at the lateral lip of the linea aspera, which is why the short head does not cross the two joints, only the long head does. The insertion's all going to be, so for the tendinosus and membranosus, it's going to be on the tibia. For the biceps femoris, it's going to be on the fibula. And then for the adductor magnus, you actually have an adductor tubercle on the femur. So it's weird, but the but the hamstring portion attaches to the adductor tubercle of the femur. The adductor portion would have been nice if it attaches to the adductor tubercle on the femur, but it doesn't. It actually attaches to the linea aspera. And then innervation, they're all going to be sciatic. But remember when we said only the short head of the biceps femoris gets the common fibular portion or division. Everything else is tibial, 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 tibial. And then they're all going to flex the leg, extend the thigh, flex the leg, extend the thigh. Because think about it, if you are at the back, so if you're starting from the back of your pelvis, which is like the ischium, and you're going down to the back of the leg, you are when you shorten that tendon, you are bending the leg. So you're flexing the leg, but you're extending the thigh. So the difference between the thigh and the leg is the thigh, the flexors are anterior, whereas in the leg, your flexors are posteriorly. Same thing with the foot. Because you remember the embryo stuff where you get the 90-degree rotation, whatever, blah, blah, blah. Okay. So same thing with the biceps femoris, flex, extend the thigh. You'll also get some rotation of the leg with the biceps femoris. The adductor magnus does not have an effect on the leg, but it'll also extend the thigh. And then remember, it does some flexion because it's technically an anterior. It's attached to both anterior and posterior, but more posterior. So aids in flexion, but it's more like extension of the thigh. Anything else? No. Okay. So biceps tendon relationship. I think they asked like 4 or 5 questions of the biceps femoris tendon on maybe second exam. But key things: inserts on the head of the fibula. The LCL. So anytime we say LCL, lateral collateral ligament, that's the same thing as saying fibular collateral ligament. Think about your fibula as the lateral bone. So fibular or lateral is the same thing. So that also means medial or tibial are going to be the same thing. So MCL and TCL are the same thing. So dumb. I don't know why they have 2 names, but that's how it is. So the LCL goes between the short and long head. So that's a key thing they've asked before. Another key thing is that the biceps femoris is one of the pop fossa boundaries. So when we do the knee stuff, we go over pop fossa, you'll see that again. And then where it goes, so because it's going to the fibula, right? Because we said it goes to the fibula. That's also the direction that the common fibular nerve goes. So if you have like damage to the biceps femoris muscle there, it could also in that area damage the common fibular nerve, which they've asked before. But if they ask specifically like the long head is damaged, then and what nerve innervates it, then it's tibial division of sciatic. If they ask short head, what nerve is damaged, common fibular division of sciatic. But if they just say like what other nerve is in that area, then it's common fibular. Okay, pes and serenus. So these are the muscles that, remember we said act on both the hip and the knee. So what's unique about them is they all come from different compartments, so they all have different nerve supplies. So sartorius is coming from the front. This is your seatbelt muscle. So remember, pes and serenus is like the goose foot looking thing, where you have like 3 muscles attached to the same side, and it looks like something like this. It looks like a goose foot at the end. It's like the medial side of the tibia, like medial superior tibia. So sartorius comes from anterior, gracilis, which is an adductor, comes from medial, and then semitendinosus, which is a hammy, comes from posterior. So remember, anterior compartment is going to be femoral, medial is going to be obturator, posterior is going to be the sciatic, specifically tibial portion. Which terminal branch supplies the greatest number of lower extremity muscles? It's going to be the tibial, because that's going to do all the posterior muscles from your gastro, soleus, plantaris, all the way to the deep ones, which is your tibialis posterior, and then the stuff for your big toe, other toes, and whatever, popliteus that we'll go over. Okay, sciatic nerve. The nerve roots are L4 to S3. It's going to do the posterior thigh muscles, so your hamstrings, which we've already seen so many times. So biceps femoris, semitendinosus, submembranosus, also hammy portion of adductor magnus. So don't forget that. Oh, never mind, it's here. So dumb. Oh, I need to sleep. Okay. So there's no sensory function directly for sciatic, but if it's going to split into the tibial and common fibular, which will then split into deep fibular and superficial fibular. Remember, superficial fibular later is going to do like the dorsum or top of the foot. Deep fibular is going to do like the first web space of the foot. And then you're going to get a branch from tibial, which is medial sural. You're going to get a branch from common fibular, which is communicating sural. And together they're going to give you your sural, which is going to do like the back of the leg and then lateral foot and whatever. So like the sciatic nerve itself does not do sensation, but it gives off branches which do. So indirectly it does all that stuff, whatever, through the terminal branches. And then we already talked about the branches, tibial, common fibular, and the pop fossa. And then we said under the piriformis and the greater sciatic foramen. And then down the back of the thigh, right before it branched off the pop fossa. A key thing that she asked about is there was a question that was like, you have damage to your sciatic nerve. Which of the following nerves would be damaged or something? And this was the concept where she was, remember when we talked about the thing where it was like the F's go to the back? So femoral and common fibular nerves are dorsal roots, whereas tibial and obturator are ventral roots. So the nerve roots themselves for obturator and femoral are the same. They're L2 to L4. Remember, these are the ones where femoral goes lateral to the psoas major, whereas obturator goes medial to the psoas major. So obturator, femoral are both L2 to L4. Tibial and common fibular both come from sciatic, so they're all of these. L4 all the way to S3. But the difference is that tibial is ventral or anterior L4 to S3, whereas common fibular is dorsal L4 to S3. Femoral is dorsal L2 to L4, whereas obturator is ventral L2 to L4. So if they say there's a problem with one of your adductors, your obturator nerve is damaged, so it is ventral L2 to L4 nerve roots. If there's something damaged with one of your quads, or you're doing like the patellar reflex for L2 to L4 to test your quads, that would be the dorsal L2 to L4 nerve roots. So the question they had was, if your sciatic nerve is damaged or something like that, which of the following, there was like multiple answers, would also be damaged? So it would be both ventral and dorsal L4 to S3, because tibial is ventral, common fibular is dorsal. I hope that makes sense. Trendelenburg gait, we just went over it. So it's a superior gluteal nerve injury because of gluteus medius and minimus, and then the opposite side drops. So you have a right, so if you have left foot is off the ground, right gluteus medius and minimus contract, keep the hips stable. But if the right superior, this should be superior gluteal nerve is injured, then they can't contract, so the left side is the one that actually drops. So just think of it, if the left side drops, it's the right superior gluteal nerve injury. It's because your right gluteus medius and minimus are damaged. That's it. All right, we're done with the thigh stuff. For the legs, anterior compartment. So all the stuff anterior leg. Actually, sure, let's do this. So this is all anterior compartment. This is lateral compartment. And this is all posterior compartment. But the posterior gets split into deep and superficial. What you notice about the superficial posterior, no blood vessels, no nerves here. It's literally just gastro, plantaris, soleus, nothing else. All the blood vessels and stuff are going to be in the deep compartment. So the deep compartment, you're going to have your tibialis posterior. You're going to have, where in the back, remember we said in the legs, or in the leg, the back is where your flexors are. So flexor hallucis longus and flexor digitorum longus. And then you also have your popliteus, but you can't see it here because what you're looking at over here is like if you had someone laying on their back and their legs were towards you and you just cut their leg at a specific part, like halfway through their leg, and you're looking up. So you threw away the part that you cut and you're looking up at their leg. This is what you're looking at. So this is the back part, posterior, anterior, lateral. And then obviously from the bones, you can tell that this is the tibia, this is the fibula, based on the size. Which helps because now you know that this is the lateral side, because on the fibular side. So, remember, for the posterior compartment, we said the vessels are posterior tibial artery and vein, but the nerve is just tibial nerve. Anterior compartment, it is anterior, where is it? Anterior tibial artery and vein, but the nerve is deep fibular nerve. And then for the lateral, you don't have your own artery because you get perforating arteries from the other two compartments, but you have the superficial fibular nerve, and then these are the muscles. So longus and brevis are laterally. Anterior versus posterior is nice because if we had a tibialis posterior, here we have a tibialis anterior. If we had a flexor digitorum longus, flexor hallucis longus, now we have extensor digitorum longus, extensor hallucis longus. The key one that they love to ask about is the fibularis tertius because that's an anterior compartment muscle. The other thing they love to ask are about antagonists at different joints. So at the talocrural or the ankle joint versus the subtalar, which is the, well, it is the subtalar joint, but this is where like you get inversion, eversion. This is where you get dorsiflexion, plantar flexion. You have antagonists at each of these joints. So if she asks, actually let's go over these muscles first and then we'll go over that stuff. So for anterior compartment, the stuff anteriorly is going to be tibialis anterior. You have your extensors anterior, because remember posterior is going to be your flexors. Anterior is going to be your extensors. And then fibularis tertius, then we went over all of these. The lateral stuff is going to be the eversion. They also do weak plantar flexion. So the only thing that does dorsiflexion are the anterior ones. And then posterior, remember P posterior, P plantar flexion. And then we went over posterior tibial artery and vein, tibial nerve. And the superficial muscles, gastrosoleus plantaris, deep are these. Remember, don't forget the popliteus. It doesn't go all the way down to the foot. Obviously, it stays behind the knee. And then for the lateral, it has its own nerve supply, but not own blood supply. So if they ask, or she could ask, which of these two muscles, and it's one of those like 1, 2, 1 and 3, whatever, are antagonists at the subtalar joint. So subtalar joint is going to be where you get inversion, eversion. So if she says they're antagonists at subtalar, but not at ankle. So in other words, they do the same thing at the ankle, but they do opposites at the subtalar. That would be tibialis anterior and fibularis tertius, because they both dorsiflex. So they're not different. They're not antagonists at the ankle joint, but they are at the subtalar joint because tibialis anterior will do inversion, whereas fibularis tertius will do eversion. So I hope that makes sense. Now, if they said which of these are antagonists at both ankle, sometimes they'll say like talocrural, because that's just saying tal is connected to like your higher part or your leg. Antagonist at both ankle and subtalar. Now you want two muscles that'll do opposite at the ankle, so dorsiflexion versus plantar flexion, and opposite at the subtalar, so inversion versus eversion. And that would be something like tibialis anterior and fibularis longus, because one does inversion, one does eversion, but tibialis anterior is going to do dorsiflexion, whereas fibularis longus is going to do weak plantar flexion. Even though it's weak, it's still an opposite. So this could have been brevis as well versus tibialis anterior, for example. Let's say they asked which two muscles are antagonists at the ankle joint but not at the subtalar joint. So you want them to do the same thing at subtalar, so they both invert or both evert, but you want opposite at the ankle. So fibularis tertius and fibularis longus will both evert, but one does dorsiflexion, one does plantar flexion. So I hope that kind of makes sense. I'm trying to see what else can they ask? They could ask which two muscles are antagonists at the transverse arch, for example, which is like the bottom of the foot on the plantar aspect. So think about which muscles insert at the bottom of the foot and do different things. So tibialis posterior, let me use a different color. Tibialis posterior and fibularis longus both insert at the bottom of the foot, because remember, tibialis posterior is going to go to the navicular tuberosity, so more it's like bottom medial, whereas fibularis longus has like that long grout where it goes under the trochlea and then it goes all the way through like the cuboid sulcus and a bunch of things, because it's coming laterally all the way to the bottom medially to like the medial cuneiform / first mat. So both of those insert there. They're where the transverse arch is, and we'll go over the medial, lateral, and transverse arch on the bottom of the foot later. But they do different things, because fibularis longus is going to do eversion, whereas tibialis posterior is going to do inversion, which I should probably put here. So both tibialises do inversion, the anterior and posterior. So that's something else they could ask, the difference between tibialis anterior and tibialis posterior. So they do the same thing at the subtalar joint because they both invert, but they do opposite things at the ankle joint, dorsiflexion versus plantar flexion. So I hope that makes sense. Okay. All right, Achilles tendon at its insertion and all the structures it's related to. So the Achilles tendon is going to insert at the middle facet of the posterior calcaneus. Remember, the inferior facet is where you have your fat pad, and the superior is where you have your retrocalcaneal bursa. The question they've asked before is, well, there were a couple. One of them is like, what fibers of the soleus and gastro are at like the point of attachment on the calcaneal tendon? And remember, there's like a little rotation at the end where like the soleus goes more medial than the gastro. So soleus is more medial, and then gastro is more lateral. The other thing they love to ask, or that she has asked before, is what is between the retrocalcaneal and the subcutaneous calcaneal bursa? And that is the Achilles tendon. So if you zoom in all the way here, when we say retrocalcaneal bursa, remember, so calcaneus can attach at like the middle facet. On the bottom is going to be like your fat pad. At the top is where your retrocalcaneal bursa is. Between your retrocalcaneal and subcutaneous is going to be like just like right under the skin. What's in between them is this Achilles tendon. So that's what separates them. That's a question she's used before. So yeah, so they could talk about the fibers, where the soleus are medial, gastro is lateral, or that stuff. Usually if the Achilles is going to get ruptured, it's like 2 to 6 centimeters proximal to its insertion. So like higher up than its insertion, 2 to 6 centimeters. And that's because of poor blood supply, and that gets worse with age and whatever. Oh, you can also get Haglund's deformity, which can irritate the retrocalcaneal bursa and the Achilles tendon. So Haglund's deformity, the way I remember it, is pumpkin spice latte. So it's PSL. It's posterior, superior, lateral calcaneus. So posterior, superior, lateral calcaneus. So your retrocalcaneal bursa is there, the Achilles tendon is there, so it could damage a bunch of things. Okay, common fibular, defibular, superficial fibular injuries. So we know that common fibular splits into deep and superficial. So this happens at the neck of the fibula, which she loves to ask. So if your common fibular is damaged, then everything that your deep and superficial nerves do is also damaged. Now, if she says someone got hit on like the lateral, you got hit on the lateral side of the leg, and now you have weakened eversion and loss of sensation on dorsum of foot, that's going to be just superficial fibular, because it just says loss of sensation dorsum of foot. In this case, they would have said like the first web space is spared. That's why there's like no deep fibular damage. They also would have, like if the deep fibular was also injured, you would have had loss of dorsiflexion, because remember, deep fibular does anterior compartment. And then the reason you have weakened, not complete loss of eversion is because you still have on your deep fibular or anterior compartment, which is innervated by deep fibular nerve, you still have the fibularis tertius there, which can do eversion. She's asked before, like, superficial fibular, or like which nerve does like most of the dorsum of the foot, superficial fibular, and then the exception is the first web space. So between your big toe and second toe is deep fibular. So yeah, we already went over all these muscles from the anterior compartment. These are from the lateral compartment. Oh yeah, she had this crazy question too, where it was like, imagine you ripped the tendon of your fibularis longus, like you cut it off, and you moved it from behind the lateral malleolus to anterior to the lateral malleolus. What would change about it? So, in other words, they're just saying that, like, you made the longus the tertius, because now you made it like an anterior compartment muscle, because instead of behind the lateral malleolus, it's anterior to lateral malleolus. So it would still evert, so nothing changes with that, but the difference is now it is going to dorsiflex instead of plantar flexing, because the anterior compartment is going to dorsiflex. I don't know, that was a crazy question, but whatever. Trace the sural nerve. We already talked about how the sural nerve comes from the tibial common fibular. Tibial gives off medial sural, common fibular gives off communicating, then becomes sural, and it does like the back of the leg, and then the lateral, a little bit of like the foot. Okay. Tendons traveling under superior extensor retinaculum and inferior. So these are going to be all your extensors. So the anterior compartment stuff. So tibialis anterior, extensor hallucis longus, jitorum longus, fibularis tertius. And then you also have anterior tibial artery and vein. And then the nerve is deep fibular. Yes. Okay, anterior tibial artery and vein. There's a few differences between the superior and the inferior extensor retinaculum. The key thing is inferior is going to be Y-shaped, so you can literally see here how it's like Y-shaped like that. The other thing is over here, the artery is called anterior tibial artery. Is it in the picture? Maybe not. Over here, the artery is still called anterior tibial, but down here it's called dorsalis pedis. So that's an important thing. Oh, here it's still anterior tibial. The Y's, you can see how like they diverge. One will go like towards the medial malleolus. The other one's gonna go and merge to the plantar aponeurosis on the bottom of the foot. What else is important? The order of the muscles in the extensor versus the flexor side. In the extensors, it's Tom Haystick, so it's tibialis anterior, then the extensor hallucis longus, then the extensor digitorum longus. Whereas on the back of the leg, remember how they go behind the medial malleolus through the tarsal tunnel, and then it's Tom, Dick, and Harry. Tom, Dick, and very nervous Harry, because it's artery, vein, nerve, whatever. But it's T, D, then H, from medial to lateral. So the only thing that really changes is the D and the H. And I think that's it for that one. You also have a fibular retinaculum, which is on the side. The superior one will have both the tendons of the brevis and the longus, but the inferior one, they each separate, so they each have their own like tendon. That's like the only like key thing there. Okay. Superficial versus deep posterior compartments. This is the stuff we've been talking about, where the superficial is going to be your, let me go back to blue. Superficial is going to be your gastro, soleus, and plantaris. All the plantaris really does is just assist the gastro and plantar flexing. And then it also goes to the knee, because the gastro also goes to the knee. So you have a lateral head, lateral aspect of lateral condyle of femur. Medial head's going to be medial aspect, medial condyle of femur. The key thing is it goes to the knee, whereas the soleus does not. The soleus starts at the leg. So you have the fibula attachment, you have a tibia attachment, there's a literal soleal line, and then the arch in between them. So soleus does not go up to the knee. So the soleus is the main plantar flexor, because it does not rely on the knee. Whereas the gastro depends on the knee, it'll plantar flex or not. So if your knee's like fully bent, you can't really plantar flex anymore. It's like if you curled your bicep all the way up and then someone was like flex, like you literally cannot flex anymore. So I think there was a question once where she was like, when is the gastro like most effective? And it's like when you're like mostly dorsiflexed, because now it gives it the range to fully plantar flex. So in like dorsiflexion and knee extension is when, or sorry, knee flexion is when it, wait, plantar flex ankle. Yes, in dorsiflexion and knee extension is when it's like most, where it has like the most impact, because now it can fully plantar flex and flex the leg. So pretty much the opposite of this. It's like if you extend all the way, now you have more to like flex your bicep if you want to think about the arm. And then when you're fully flexed, now your triceps have like the most impact or like range possible for them to work. The nice thing about these is they all have the same insertion. So calcaneal tendon, calcaneal tendon, calcaneal tendon. All same nerve, tibial, tibial, tibial. The soleus, we said, is the main plantar flexor. It's also the thing that like keeps you balanced. And then remember, independent of position of knee. This is like so important. The other thing she asked is like, where does the tibial nerve pass through in the back of the leg? And there's like an opening in the soleus called the soleal hiatus, just like how the adductor magnus has an opening called an adductor hiatus. So the tibial nerve goes through these, and then the popliteal artery and vein goes through these as well. Plantaris, we said weakly assists the gastro. It also part of its origination is like the oblique popliteal ligament, which is like the back of the knee. Sorry, plantaris, not popliteus. Popliteus is the one that unlocks the knee. So this is the one that's going to laterally rotate the femur on the tibia. That's how she words it. That's how we're going to use it. You're laterally rotating the femur on the tibia. This will unlock the knee, which will create like slight flexion. It's not like a big flexor. It's just like the beginning part of flexion, which unlocks the knee. So your knee is locked when your knee is fully extended. So if she asks what fully locks the knees, those are your quads. So quads lock, whereas popliteus unlocks. Then it goes from lateral femur to medial tibia, or like back of tibia if you want to think of it that way. Also tibial nerve, it's just the nerve roots are different. The other ones were S1, S2. This one's L4, L5, S1, S2. For the toes, so the flexor hallucis longus, flexor digitorum longus, the way I remember the nerve roots is we have 5 toes, and if you're going to have 2 nerve roots in a row that add up to 5, you're going to want 2 and 3. So 2 plus 3 is 5. The hallucis longus, so with the flexor and extensor hallucis longus, so whether we're at the posterior or anterior compartment, usually it's going to start on the fibula, whereas the digitorum is usually going to start on the tibia. But you'll also get like a little bit of the fibula and whatever. All these stuff are like kind of like in between tibia and fibula. Some have like specific origins. She hasn't been too crazy with like the origins. If anything, she's been more specific at the insertions, which make more sense, because if we're talking about the hallucis or toe, it's going to insert at the base of the big toe, at the distal phalanx. Remember, for the phalanges, we have 14 phalanges. There's 3 in every toe except for the big toe, and then the big toe has 2. So for the big toe, phalanx, phalanx. Others are phalanx, phalanx, phalanx. So only the big toe only has 1 interphalange because it's between 2 phalanges, right? Inter. So you can only have 1, whereas the other ones you have a proximal interphalangeal joint and a distal. Proximal, distal, proximal, distal, proximal, distal. So 14 total phalanges, 9 total interphalangeal joints. So flexor hallucis longus, it's in the posterior compartment, so it has to dorsiflex. Sorry, plantar flex. Plantar flex. Sorry. Plantar flex. It's going to plantar flex the ankle, and then it's also going to flex the interphalangeal joint of the halix. So plantar flex is for the ankle. So if you want to fix this, for the IP joint of the halix, it just flexes. And then because the big toe is on the medial side, and now we're talking about the bottom of the foot, because the stuff on the back of the foot is going to go to the bottom of the foot, is going to support the medial longitudinal arch of the foot. For the FDL, for the other toes, they're like more in the middle. They're not like medial or lateral, so they're going to do both medial and lateral longitudinal arch of the foot. And now these, because you don't just have 1 interphalangeal joint, because we're talking about the other toes, you have to specify where, and it's the distal or dip. So again here, it's plantar flexes ankle, but it flexes the DIP. Okay, then tibialis posterior. So this starts on the interosseous membrane. There's a question that she asked where it was like all of these are continuations of the crural fascia, which is the deep fascia of the leg, except, and the exception was interosseous membrane. So again, this will be like on fibula, but also on tibia. And it's going to insert on like everything on the bottom of the foot, except the talus, because the talus does not have any tendon attachments. So if she asks which bone has no tendons attaching there, no tendon attach, whatever. If she asks which bone does not have a sulcus, it's the medial cuneiform. So she's used those 2 before. Specifically, though, it's going to insert on the navicular tuberosity. I cannot write for sure. Okay. So it's in the posterior compartment, so it has to plantar flex the ankle. Remember we said both tibialises, anterior and posterior, are going to do inversion, and that's at the subtalar joint, not at the ankle joint. And then it's also on the medial side. So just like the hallucis, it also supports the medial arch. So only the digitorum does both medial and lateral. And then it's also tibial nerve L4, L5, which is the same as anterior or tibialis anterior. Okay. Well, arteries supply the gastro and the soleus. So for the gastro, it's the sural arteries. Medial for medial head, lateral for lateral head. And then these are branches of the popliteal artery. So popliteal will give off sural. That will supply the gastro. For the soleus, you get a bunch of them. So you'll get sural proximally, but then you'll also get some posterior tibial. You'll also get some fibular on the lateral side. So it's a bunch of them. The fibular artery, remember we said it's a branch of the posterior tibial artery because that's the one that gives perforating branches to the lateral compartment. And then it's going to supply some of the stuff on like the posterior lateral side. So flexor hallucis longus, fibularis longus, brevis, lateral portion of soleus. Remember we said the hallucis starts at the fibula, so it makes sense that it gets some of this as well. And then if you're going to supply a portion of the soleus, if we're talking about the fibular, you want the lateral portion. And then these make sense because these are the main ones. So if anything, these are the main ones. And then it has the perforating branch, which we said goes and supplies the longus and brevis. A key thing about the perforating branch is it pierces the interosseous membrane, which is between the tibia and fibula, so it pierces it to supply the other side. Has a communicating branch, anastomosis of the posterior tibial. And then the question that she's asked is what does the fibular artery end as? And it ends as lateral calcaneal artery. So she could ask that again. Which supplies lateral heel calcaneus, so anastomosis of the medial, blah, blah, blah. Okay. I hope it knows by now. Dorsiflexors are going to be the anterior stuff. Plantar flexors are going to be the lateral and posterior compartments. Attachment of the ankle joints. So on the lateral side, so think of what is there, right? So the talus can connect to medial or lateral side because it's kind of in the middle. But if you're going to connect on the lateral side, it's going to be to the fibula. On the medial side, it's going to be to the tibia. So the lateral ankle joints are going to be talus to fibula, talus to fibula, anteriorly and posteriorly. The posterior one is the strongest lateral ankle ligament. So out of these three lateral ones, the posterior talofibular ligament is the strongest one. Also on the lateral, it's going to be something that attaches to the fibula, so it's going to be the calcaneus to fibula. The stuff on the lateral side would be damaged if you have an inversion injury, which she's asked. So usually if you're plantar flexed, so when you plantar flex, think of the shape of the talus. The front of the talus is like wider than the back. So when you plantar flex and this goes down and this part goes up, your ankle's like barely hanging on anything right here. So it's easier to damage. Whereas if you dorsiflex and this part comes up, your ankle's like more locked. So if you plantar flex and then you invert, so the big toe side comes up, you can damage the lateral side, which is like the common basketball injury. So if she goes like basketball, injury, inversion, whatever, which thing's damaged, you can either say the lateral ankle ligaments, or you could specify the anterior talofibular ligament is the most commonly damaged one. The posterior one is the strongest. And then calcaneofibular just goes calcaneus to fibula. The medial ones, there's more of them. And these ones are like more stable, if you want to say. So tibia to navicular, tibia to calcaneus, tibia to talus, both anteriorly and posteriorly, and superficial and deep. So there's a bunch going from tibia to talus. For the superior, posterior tibio-talar, we're going from medial tubercle of talus to the tibia. Whereas in the posterior talofibular, so talus to fibula, we went lateral tubercle. Talus to tibia, we're going medial tubercle. Remember the tubercles are in the back of the talus, where it's like your flexor hallucis longus will like go in between them, and it's going to go under the sustentaculum tali of the calcaneus and whatever. So that's what those are what your tubercles are. Something she's asked is if you have damage. So the main one is the basketball injury one, and then I think she had one like where does the posterior talofibular attach, and it was like lateral tubercle, or this one was like medial tubercle. But the other one was if your deltoid ligaments are damaged, what could be subluxed or like kind of taken out of its place, and it's the medial malleolus. Because everything on the medial side that's connecting to the tibia starts from the medial malleolus of the tibia. Because they're all tibial something. And then they attach to either medial tubercle of the talus or whatever, the medial side of the body of the talus, or something for the calcaneus. If we're going on the medial side, we're going to sustentaculum tali. If you're going to the navicular, you're going to the dorsomedial side. But if they're going to ask something, I think she would ask that again. But the rest, I mean, the name just says where they are and where they attach. Okay. Neat stuff. So for the pop fossa, she's asked about the boundaries before. The top boundaries are going to be, let me see if we have them here. We do have them here. So superior, so it's going to come supermedially is semimembranosus, superlaterally is basilis femoris. This is the one where she asked like 5 different questions about. And then coming from the leg from the bottom, inframedially is going to be medial head gastro, infralaterally lateral head gastro. So this right here is your pop fossa in the middle. From superficial to deep, it goes nerve, vein, artery. So the nerve, it's not sciatic anymore because it splits. So it's tibial and common fibular, but the one that's really like right on the vein artery is the tibial. So when you say nerve, we're saying tibial nerve. And then vein is popliteal vein, artery is pop artery. So this is the deepest, and then remember we said if it's the deepest, we're looking from the back, it's the most anterior. There was a question she asked, which of the following muscles is both a boundary and a floor of the pop fossa, and it was the semimembranosus. We did the superficial to deep. This is where like your femoral becomes popliteal. It's after the adductor magnus, hiatus. What else? She didn't really do like clinical stuff, but if you're gonna palpate someone's popliteal pulse, you want them like prone, so on their stomach, they flex their knee, because if you think about it, the artery is so deep that like you gotta like get them to bend it to like really feel the artery, or you gotta feel it at like the lowest part, which is like right on the tibia, because you're not gonna feel like right in the back of the knee because it's so deep. If someone does not have a popliteal pulse, first of all, you have to make sure you did it right to check for their pulse, because that could be the issue. But if you did it right and you don't feel a popliteal pulse, then you have to go up and check the femoral pulse. If the femoral pulse is there, then there's some blockage between the femoral pulse, which is the femoral artery, and the popliteal artery. If you don't feel the femoral artery, then you got to go higher up, because that means there's a block much higher up. I mean, you can kind of skim over this stuff. None of this stuff is like stuff she really like hammered. The popliteal lymph nodes, those are like the deep lymph nodes. That's where your small saphenous vein will drain into popliteal vein. And then it goes from like superficial to deep. Because popliteal is deep. Femoral vein is deep. The great and small saphenous veins are superficial, so it goes superficial to deep. The other thing is, from your popliteal, so when you drain into your popliteal, you want to go from popliteal all the way up to femoral, so you're going from deep to deep. But remember, there's a medial great saphenous also draining into the femoral, so sometimes from the popliteal, some will drain into the superficial great saphenous. So popliteal lymph nodes will drain into both superficial and deep. The superficial ones are the ones that will go into like the great saphenous one. The deep ones just go straight into the femoral. And then we went over the boundaries. Oh, she had a question. It literally just said, what attaches the menisci to the tibial plateau? And it was the coronary ligament. You can see it's like on the bottom here. So it attaches the menisci to the tibia. The bursae around the knee, a lot of them are like within the name. So it's like suprapatellar, above patella. Popliteus can be where your popliteus is. Anserine, it's where your pezcenserinus is. Deep to the medial head of gastrocnemius. So the nice thing is like they're all within the name. The two questions she's asked about this is, the first one was if you are going through the bottom, or if you like poke or like go through under the patella, what do you not hit? And the answer was the suprapatellar bursa, which is this thing right here. The other thing she loves to ask and emphasize so much, and did ask, is what stabilizes the patella the most? And it's the MPFL, the main patellar stabilizer. It's on the medial side, so it'll prevent like lateral subluxation. And the stuff's in the name, like the lateral one will prevent medial subluxation. Like altogether, they hold the patella in place, but the main one is the MPFL, patella to femur on the medial side. Okay. For the drawer sign tests, anterior drawer sign, you check if the ACL is torn. So what you do is you grab the tibia and you try to pull it anteriorly. If you can move the tibia too much like anterior relative to the femur, they have an ACL injury. Posterior drawer sign, which is the one she actually asked, is if you move the tibia posterior too much to the femur. Sometimes they'll play around with the words. So if they say the femur is anterior to the tibia, it's actually a posterior drawer sign. Because if the femur is anterior, that means the tibia is posterior. So always relate it to the tibia. That's how I think about it. If the tibia goes too posterior, PCL tear. Tibia goes too anterior, ACL tear. For valgus and varus stress, so valgus is like the Disney knees, like the Disney Channel people used to dance, like their knees were literally like this. So what you're doing here is you're pushing the lateral side too far in. And if you can push it too far in, so this is your LCL. If someone gives you a valgus stress like this will kind of like open up. And if you can open too far, that means there's no MCL. So that's how you check for a torn MCL. And then you do the opposite. So you'd put, for varus, the legs would be like this. So you're pushing in this way to see if this opens up too much and there's an LCL tear. The way I remember it is like, I know it's weird, but it's like the opposite. The one with the L tests the MCL. The one without the L tests the LCL. I don't know if that helps. It's like the opposite. What else? Anything else here? Nope. Okay. ACL. So between the ACL and the PCL. So ACL and PCL are cruciate ligaments. The other ones are collateral ligaments. So don't get the names confused. And remember when we said for MCL and LCL, you can also say tibial or fibular. Between ACL and PCL is way stronger, so it's like harder to tear. ACL is like the more commonly torn one. Goes from anterior intercollar to tibia to the posterior medial meniscus. Poor blood supply. What else? So if it goes from anterior tibia, then it's going to go to the back of the femur. So posterior, lateral. It's like the medial side, the lateral condyle of the femur or whatever. What else is important? Usually when you tear your MCL, so here, let's go down to MCL. Your MCL is, and they do not have the picture here. That sucks. Okay, so your MCL is attached to, okay, I have it here. It's attached to your medial meniscus, unlike the LCL. So when you tear your MCL, you also tear your medial meniscus, and then many times, if it's like a bad enough hit to where like you took like a lateral hit, you'll also tear your ACL. And this is called like the unholy or unhappy triad. And then you do the tests the way we did them before, whether it's a valgus or varus or anterior or posterior drawer test. Key thing is posterior PCL is stronger than ACL, and then LCL is stronger than MCL, which makes sense. Then the unhappy triad, it's the weaker ones that are being damaged. The MCL is the weaker one. The ACL is the weaker one. LCL is like more cord-like. It's strong, not attached to lateral meniscus. Oh, these are two key points. So the popliteus tendon goes deep to the LCL or FCL, which shows us that the LCL is separate from the lateral meniscus because there's something going in between them. So if she says what is in between the MCL and the medial meniscus, sorry, the LCL and the lateral meniscus, it's the popliteus tendon. And then if she says what is split by the LCL splits the two heads of the biceps femoris, the long and short. Then we already said MCL, valgus, LCL, varus. ACL is gonna be like for hyperextension injuries. PCL is gonna be like kind of like, it's like hyperflexion, but it's more like when your knees flex and like you land on the front of your tibia. So it's like a more weird, like it really takes a lot of pressure to tear your PCL compared to your ACL, as we saw with Derrick Rose. Oh my God, you're so good. Okay. Intracapsular, intrasynovial. Okay, so sometimes I think she only asked this once actually. She said which of these is like extracapsular, and she either put LCL or MCL as one of these. But if you think about it, if you're intracapsular and intrasynovial, you're like in like the middle of your knee. So it makes sense. Your menisci are there. Your transverse ligament, which connects your menisci, also there. And then what connects your menisci to the femur up is also there. So we're talking about like in the middle, like right here. This stuff. The other stuff, so ACL and PCL, we're still intracapsular, but we're not intrasynovial anymore because like they come more like inside and outside, but they're still in the middle. Whereas MCL and LCL are just completely out of it. They're extracapsular. So extracapsular is going to be your MCL, LCL, and then the thing all the way, like the front, the patella ligament, and the stuff all the way in the back, the oblique and arcuate. Whereas intracapsular, but outside of the synovial, is going to be your ACL and PCL. I think we already said this. Yep, tendon popliteus deep to LCO. All right, there's a lot of repeats. Okay, genicular anastomosis, then we get to the hip. So for genicular anastomosis, if she's going to ask something, I think she's going to ask either what is the last branch of the femoral artery, and it's going to be the descending genicular artery. The other thing she could ask is if you lose blood supply from your popliteal artery, what is like the main artery that can provide like the collateral pathway? And it's the descending branch of the LFC artery, which comes from deep femoral. This shows like the rest of the stuff. Remember for the geniculars, like you have a superior medial, superior lateral, inferior lateral. Then you can't see it, but there's also like a middle one here. The middle one doesn't contribute too much to the collateral network. So you can see here, middle genicular artery, minimally to the collateral network. It just like supplies the knee joint itself because it's like in the middle and it goes like straight anterior. And then this anastomosis is important if you have popliteal artery occlusion, which is what we said, trauma, aneurysm repair, or clamping. So it's between the genicular arteries and the descending branch of LFC, which is a branch of the deep profunda femoral, and it's around the knee. Okay, for the hip, she had this like random question. It was like, which of these is the most medial? And she had a bunch of acetabulum stuff, and then she had ilium, and the answer was ilium. I don't know what kind of question that is, but that's what it is. She also loves like the accept ones. So she says like which part of the head of the femur is not covered with hyaline cartilage, the fovea capitis. What else? The acetabular fossa and notch are not covered with cartilage. But the labrum has like fibrocartilage attached. Yeah, I think if she's going to ask, it'll be something like an exception one. For the hip joint one, the one she asked was the ligaments, so iliofemoral, ischiofemoral, and pubofemoral. So these are all ilium to femur, ischium to femur, pubis to femur. What do they prevent? And they prevent hyperextension, all of them. For dislocation of hip joint, I think if she's going to ask, it's going to be like, what's the most common one? It's going to be the posterior dislocation. And then, remember, posterior, it's going to affect more of your sciatic nerve, whereas anterior is going to affect more of your femoral nerve. Anterior is way more rare. Like, it's crazy to have your, like, for the femoral head to come anterior to the acetabulum, you're going to have, like, some crazy injury. Even, like, a central dislocation one. Like, this one would have to be, like, for it to go like medially into the acetabulum, you're gonna have to have like some crazy like motor vehicle crash or something where it's like something really shoved it into the acetabulum. So the common one is posterior dislocation. She didn't ask about these before, but the way I remember it is A and B go together in the alphabet. So anterior dislocation of the hip, you do the Barlow test. O and P in the alphabet go together, it's like LMNOP, whatever. So Ortolani is the posterior dislocation of the hip. And then to do an Ortolani, you move the head into the acetabulum, whereas for the Barlow, you move the head out of the acetabulum. That's how you test it. And then you can have like congenital, where it's like birth stuff, or it could happen through trauma. And I think, yeah, that's all there is for that. Okay, now that we're at the foot, so foot drop. If the foot drops, you can't lift it up. You can't bring your toes up, so you can't dorsiflex. And if you can't dorsiflex, it's going to be either a deep fibular, because that does anterior compartment, or common fibular, which branches off to deep fibular and superficial fibular. So also you're damaging the anterior compartment. But the common fibular will also affect lateral compartment. Also, it can also happen if you get an L4, L5 disc herniation. Remember, disc herniations always affect the lower nerve root, so it's L5. And that could happen to like due to a lumbosacral plexus injury. But this would be like more crazy because you're like damaging way higher up. So like way more things than just foot drop would be going on. Portopetus, the key thing is it's under the abductor hallucis. And this is where you'll have where is it? The like terminal branches of the posterior tibial artery which are coming from the flexor retinaculum, they'll go into the foot. So it's like a port to go into the foot through the tarsal tunnel and the portopetus. And it's on the usually like your medial lateral plantar arteries, which are the terminal branches of your posterior tibial. That's how they get to the bottom of your foot, through the port. She just straight up asked like, where do you get heel spurs, and it's on the medial process of the calcaneal tuberosity. The sensation to the hallux, if she's going to ask, it's probably going to be an exception one. So the medial side is still going to be superficial fibular, because superficial fibular we do like most of this stuff except like this first web space here, which is deep fibular. So if you're going lateral, it's going to be deep fibular. If you're going superficial, if you're going medial, it's going to be superficial fibular. On the plantar side, it's nice because the medial plantar does both medial and lateral sides. So medial plantar is going to give something that's going to go medial and lateral. Okay. For the calcaneal fat pad, so remember how we said the medial facet gets the Achilles tendon, superior facet, so now we're at the back of the calcaneus, gets the retrocalcaneal bursa, and the inferior facet is where you get the fat pad. The question she asked was like which part or something. It was like superficial or deep, or she gave a bunch of other options, and that's why this is exclamationed out, because it's the superficial plantar fascia. Yeah, I mean, about 2 centimeters thick. It's like a cushion in place. It's like on the bottom of your calcaneus. Obviously, if that goes away, then it would hurt when you're walking or whatever. Okay, one last mechanism. The thing she asked was what happens. And it was the plantar fascia gets like pulled distally. And then this is going to like invert the foot, and then it rotate the leg and whatever, and it's like a passive thing. Depends entirely on like the stability or instability of your bones and ligaments there. The key thing she asked was like what happens, and it was like the plantar fascia gets pulled distally. For the extrinsic tendons of the toes, so these are the stuff that are going to come from higher up, right? They're going to come from your leg. If we're talking about intrinsic, they're going to be the ones that start in your foot. So start at like the calcaneus and then go to the big toe or the other toes or whatever. Whereas the extrinsic ones are the ones that start in the leg. So we're talking about the longuses. So the anterior compartment, the dorsiflexors, are your extensor hallucis longus, extensor digitorum longus. The posterior compartment are your flexor hallucis longus, flexor digitorum longus. So we already talked about like some of their origins and insertions, but if it's going to be on the anterior side, it's going to extend the great toe, dorsiflex the ankle joint. Extend the other toes, dorsiflex the ankle joint. For the flexor hallucis longus and flexor digitorum longus, now we're on the back of the foot. So now these are going to flex the IPs, flex the DIPs, but they're both going to plantar flex the ankle. And then remember the digitorum, so we're on the bottom of the foot now, is going to support both medial and lateral arches. The hallucis is on the medial side, so only medial arch. And then for the hallucis, there's only an interphalangeal joint. Digitorum, there's proximal and distal, but specifically distal is where we bend because we attach to the distal phalange. Here it's also distal phalanx, but it doesn't matter because there's only one interphalangeal joint. Okay, now when we're talking about the intrinsic ones, so these are the ones that originate on the calcaneus. So on the dorsal side, which is the top side, remember the extrinsic ones were extensor hallucis longus, extensor digitorum longus. Now it's extensor digitorum brevis, extensor hallucis brevis. And then on the bottom side, the plantar side, it's going to be the abductors for the big and small toe. And then it's going to be quadratus plantae and flexor digitorum brevis. The quadratus plantae is the one that inserts on the extensor digitorum longus. And then remember the lumbricals originate from the, so it'll go quadratus plantae to extensor digitorum longus, and then the lumbricals come out of the extensor digitorum longus. We'll go over, I think I have a good, yeah, we'll go over the plantar layers here. Okay. What structures lie deep to the EDB? So she could either ask lateral tarsal, which comes from dorsalis pedis. I mean, you obviously have the tarsal bones there. Or it could be like the nerve, which is a deep fibular nerve. But I think if she's going to ask, it's going to be the lateral tarsal artery. That's like the main one. Attachment of lumbricals and neurosci and whatever. So lumbricals are going to the medial part of the expansion over the lateral four proximal phalanxes. And it's going to go plantar to the DTML. So more under. Or more to the bottom of the foot. Whereas the neurosci are going to go to the dorsal, or more dorsal to the DTML. Lumbricals are going to go they're going to go deep to the extensor wing. Remember, with the neurosci, the dorsal goes through it, but the plantar is going to go deep to it. So this one is probably like the unique one. This and this are the same. And then, so we have PADs and DEBs. The plantar neurosci are going to adduct. The dorsal are going to abduct. So remember how in the toes, so we have big toe. Oh my God, I can't draw toes. Second toe, third toe, fourth toe, pinky toe. Holy shit, that's such a terrible foot. It looks like, oh my God, it looks like so many things. Okay. So this is obviously the big toe. So when we're talking about like the middle part of our foot, right? This is our midline. It's actually through the second toe. So if something is going to adduct, it's going to come towards midline. So to come towards midline, we would need this to come this way. This to come this way. This to come this way. That's how you go towards midline. Away from midline is going to be away from this. So these go this way. Now, the second toe is at midline. So there's literally no way you can adduct it. You cannot bring it more towards midline because it's at the midline. So this cannot go towards midline, but either direction would abduct it away from midline. Because if it goes this way, now it's away from midline. This way, away from midline. Whereas every other toe either adducts this way or abducts that way. This toe is going to adduct this way or abduct that way. Big toe is going to adduct this way or abduct that way. So big toe adducts this way, these toes adduct that way, and the opposite way is abduction. But the second toe only cannot adduct, so it abducts in either direction. So when we say D1, D2, P1, D3, whatever, that's what we're talking about. At the second toe, you don't have any plantar interossi. So you have a dorsal on this side and a dorsal on this side, so D1, D2. Now this toe can adduct this way, so you have a plantar on this side, P1, or abduct this way, D3 now, because we already had two Ds. And this one, same thing, is going to have a plantar on this side, but a dorsal on the other side. And then this one right here is going to have a plantar on this side. So it's D1, D2, P1, D3, P2, D4, P3, whatever. But the key thing is, like, as long as you know these are two dorsals, and then with everything else it goes P, then D, P, then D, P. And then the little toe has its own abductor. The big toe has its own AD and abductor. So big toe has a separate adductor and abductor. Little toe has a separate abductor. And again, that's in like the plantar layers that we'll go over. Okay, lumbricals, they're going to flex the MTP and extend the IP, kind of like how it does it in the hand as well. For the plantar and dorsal interossi, pad, adduct, dab, abduct. This should not be digits 2 to 4. This should be 3 to 5. Because remember, you cannot adduct the second one. Okay. First lumbrical is medial plantar nerve. She's gonna ask that for sure. The difference between that and the other ones or the rest are lateral plantar nerve. For the anatomical subtalar joint, so this is not the functional subtalar joint. This is not the entire subtalar joint where inversion, eversion happens. This is just where calcaneus and talus are connected, but the most anterior part is the interosseous talocalcaneal ligament, which is like the sinus tarsi. That's as far as we go up. We don't go all the way to the anterior part of the talus and calcaneus, so we don't include the anterior talocalcaneal ligament, only posterior, lateral, and medial, because we're stopped at the anterior. The most anterior is the sinus tarsi, because it's the anatomical, not the functional. Functional would have been the entire subtalar joint. So within the sinus tarsi, you have an interosseous talocalcaneal, interosseous between two bones. What are those two bones? Talus, calcaneus. So interosseous talocalcaneal ligament. It's the strongest one. So then the sinus tarsi blends with the fibers of the inferior extensor retinaculum, whatever. Together with the cervical ligament, it's the strongest of the subtalar, but technically the interosseous is stronger. So the key thing is interosseous will limit eversion and pronation, whereas the cervical is going to limit inversion and supination. So the way I remember it is you serve, soup, in, and then a bowl. So cervical will limit supination and inversion. You serve, soup, in a bowl. And then the opposite would be the other one. So interosseous would be pronation and eversion. And then these ones, if you're going to connect the talus to the calcaneus, you want anterior, posterior, lateral, medial. We're not including the anterior because we're not going that far up, but posterior is going to be the back. Remember, that's where the extensor hallucis longus, flexor hallucis longus runs, because it goes between the two tubercles of the talus, then it goes under the sustentaculum tali. Lateral side, you have the lateral process of the talus, lateral surface of calcaneus. Medial side is going to be medial tubercle of talus, and then on the medial side of the calcaneus is going to be the sustentaculum tali. And if we're on the medial side, it could blend with like the spring ligament. And then the rest of these are kind of like within the name. So talonavicular is going to be from talus to navicular. Because they're like so close to each other, it'll be like from the talar neck to the most close part of the navicular, which is the dorsal side. Yeah, but I mean, we're on the medial side, so it's going to blend with the deltoid ligament. Calcaneocuboid, so you have two parts. You have a lateral one, which is on the dorsal side, And then the other one also on the dorsal side, but more medial, which is part of the bifurcate. Remember, bifurcate is going to go from calcaneus to navicular, and then calcaneus to cuboid. This is the bifurcate one. So this is more like calcaneocuboid part of the bifurcate ligament, whereas this one itself is just the ligament itself, calcaneocuboid. There was a question she asked that said, which of the ligaments connect to the anterior process of the calcaneus? That is bifurcate ligament. If she says to the anterior tubercle, now you're talking about like the bottom side, that's the plantar, or sorry, the short plantar ligament. So key difference. If she says process, it's bifurcate. If she says tubercle, it's plantar. The long plantar, longest ligament of the foot, attaches to like the cuboid, which also the short plantar does, but short plantar is just like the beak. Long plantar goes from calcaneus all the way to like the mets, but it'll give off a portion that also attaches to the cuboid, just not the beak like the short plantar. Yeah, and then for the... Oh, she had a question. It was like, all of these are true about the Achilles tendon except... And one of them said it's a continuation of the long plantar, which is not. So that was like the wrong one. What else? And then we'll do the MPJ and IPJ ones in their own section. But a question she had was about like the tubercles themselves. It was like, all of these have dorsal tubercles except, and it's the distal phalanges, because you don't have a tubercle there because you have to attach the nail at the end. Okay, extensor expansion. When EDL and EDB cross the metatarsophalangeal joint, they give off fibers that form this extensor expansion. So the sling in the wing will come off the extensor digitorum longus. So she could ask that. With these ones, it was more so like accept questions. So it's kind of like know a bunch of things about them. Because like one of them was like, oh, the dorsal runs through it, which was true. Plantar runs deep to the sling, which was true. And like something else was false. I put the Ohio notes in here that she also had. So probably skim over those. But I believe the one, if I remember the one she asked was, she asked something about the DTML and how it attaches from this thing right here, lateral side of first met to medial side of fifth met. And then something about the plantar running deep, whereas the dorsal running through. But there were barely any questions on that. Key thing about the DTML, no bony attachments either. What else? Long plantar, we already talked about. Attaches to the cuboid and bases of the 2 through 4, sometimes 5. And then the cuboid sulcus gives you like the tunnel where like the fibularis longus is going to go through. Because remember, it has to go all the way from the lateral side to the bottom of the foot to go all the way to like the first met and medial cuneiform. We already saw these before, but this is like the list of the stuff. So medial tubercle, you're going to want stuff that attaches medially. So talus to calcaneus medially, and then talus to tibia. Whereas on the lateral side, it's going to be talus to fibula. And then obviously these have to be posterior because the tubercle's on the back. It wouldn't make sense for an anterior one to attach to the tubercle. And then talus to calcaneus as well. Os trigonum, so these are the accessory bones. This comes off the lateral tubercle of the posterior process of the talus, so she could definitely ask that. The way she asked is like you look at an x-ray or whatever, and this thing could either be a fracture or it could be, and then the answer was os trigonum, so it could be either one of them. Sometimes you can't like really see it clearly on the x-ray. So like for example like this, you're like, oh, either that could be a fracture or it could be an os trigonum. Os tibialis externum. So if you remember that the tibialis posterior attaches to the navicular tuberosity, it makes sense that here we're talking about the navicular. So it's in the tuberosity of the navicular. It's like an unfused secondary ossification center. What's kind of cool about this is like if the tibialis posterior is attached to this accessory bone, when you remove the accessory bone, you have to like reattach the tibialis posterior. Okay, these are all the shapes of the foot bones. There's a bunch of them that are triangular, so I tried to include some of the ones I remembered. But the key things she's asked, she had a question that said, all of these are triangular except, and the answer was first met, because the first met on the back has a kidney shaped facet that goes to the medial cuneiform, and then on the front it has like a condyloid, so no triangle. I remember C's sound like S, so the C's, calcaneus and cuboid, get the S, saddle shaped. Then remember, medial cuneiform will attach to the navicular with like a pear shaped. On the navicular, it's like a peak facing up triangle shape. But on the medial cuneiform, it's actually more pear shaped. Whereas the intermediate and lateral cuneiforms, when they attach to the navicular, so navicular attaches to medial, intermediate, and lateral cuneiforms, this is like the upward triangle. These are like the downward peak triangle. But on the actual medial cuneiform, it's like pear-shaped. Sorry, these should be like here. Between the cuboid, so the cuboid is what connects to the fourth and fifth mets. So cuboid to fourth met is going to be like quadrangular. Whereas to fifth met, it's also a triangle, but it's like a lateral apex. So lateral apex is the fifth met. Downward apex is like the intermediate and lateral cuneiforms. Upward apex is the medial cuneiform. These are all the navicular. And then the way I remember it is, if you remember lock, is it on here? Is it not on here? You have like an oval shape between the lateral cuneiform and the cuboid. So I remember like lock, L-O-C. And I remember I love B, so I-L-B, between the intermediate cuneiform and the lateral cuneiform, it's B-shaped. Sometimes they say it's like vertical shaped. Then you have the inverted L between the medial cuneiform and intermediate cuneiform. She loves to ask like where the facet is. The inverted L is going to be on the lateral side of the medial cuneiform. It wouldn't make sense for it to be on the medial side of the medial cuneiform because they would have nothing to attach to, right? Because like this is the medial cuneiform. This is the intermediate cuneiform. This is the lateral cuneiform. The inverted L is right here between these two. So it's lateral to medial cuneiform, but medial to intermediate cuneiform. The one she's asked before also is like the medial talus facet is comma shaped, but the lateral one is bigger, right? Okay. Bony landmarks that you can palpate. So talar head is the key one. That's between the sustentaculum talus and the navicular tuberosity, and you would want them to evert so it's more prominent. Sustentaculum tali, so think about it, that's all like the medial bottom part of the calcaneus, or like medial calcaneus, but under the medial malleolus. So you want to go 1 to 2 centimeters inferior and posterior to medial malleolus. You also want them to plantar flex so you can see it a little better, or palpate it a little better. This just says what we said up there. We already talked about the sinus tarsi. So on the calcaneus, you have a calcaneal sulcus. On the talus, you have a talar sulcus. When you put these together, you form the sinus tarsi. And that's where you have the interosseous talocalcaneal and cervical ligament. Interosseous is the stronger one. Cervical, it's literally called cervical because it connects to the neck of the talus. Think about like where your cervical nerves are, they're in your neck. And the key thing here is it stabilizes the subtalar joint, which makes sense because this is between the talus and the calcaneus. So subtalar, under talus joint. Okay. The nerves. So the medial plantar nerve. Oh, wait, we did artery here. Okay, we'll do the nerves after. So for the arteries, the lateral plantar artery is going to be the bigger artery. So it's going to come this way. It's going to give off the plantar arch. And then it's going to give off the little pinky toe, the one that has like the long name. So ignore the name for now. It was like lateral, proper, digital, plantar, whatever. It's on the lateral side. It's going to the digit, but on the plantar side. And it's a proper because it's going to like the phalanges. Now, that's what the lateral plantar does. It's the bigger one because obviously it gives off the arch, which will then give off the plantar, the common metatarsals, which will then give off like the proper digital ones, and so on. The medial one is the one that gets kind of confusing. So medial comes in. First going to give off the superficial branch. So the superficial branch, if you want to compare or like remember the similarities, think of the superficial branch as kind of like the lateral plantar. Because they both are going to give the end toe one, so the medial one's going to give the big toe, the other one's going to give the lateral toe, and then they're both going to give off something to the arch. So lateral is going to do the arch itself and then little toe. The superficial for medial is going to do, oh my god, the big toe, and then it's going to give off only to the first three common mets. So if you remember the lateral is bigger, it makes sense lateral gives off the entire arch. Medial only gives off as much as it could, which is only the first three. So superficial, very similar to the lateral. It's just opposite sides. The deep one is where you will have this part, which goes to the arch itself instead of the metatarsals. So the superficial one goes to the metatarsals. This little fork-looking thing will go to the metatarsals, whereas the deep one goes into the arch, and then the rest goes into this first one right here. And over here, you have a few things combining. So you have the thing from the superficial branch. So let me erase all this stuff. Right here, you have the plantar arch itself. You have the superficial branch. You have the ending of the deep branch. And then from the opposite side, which we'll see when we look at the dorsal side, you'll have a deep plantar side, which is a deep plantar artery coming from the dorsalis pedis artery. It's one of like the terminal branches of it. So hopefully this stuff will make sense now. So medial plantar artery, this is the smaller than lateral. Remember we said it enters through the porta pedis and it goes between the plantar layers 1 and 2. So the plantar layers is some more like lab stuff, but layers 1, you had the abductors on the sides, so abductor hallucis and digiti minimi, and in the middle you had your flexor digitorum brevis. In the second layer, you had your quadratus plantae and your lumbricals, and those connected to your flexor digitorum longus. I think earlier I said QP connects to extensor digitorum longus. It should be flexor digitorum longus. I might have made a mistake. And the lumbricals comes from flexor digitorum longus. And then these are the intrinsic ones because they start in the foot, whereas these come from higher up. The flexor digitorum longus, the flexor hallucis longus. So those are extrinsic. And then third layer, you have the flexors for the big toe, which is brevis because we already have a longus. Flexor for the little toe. It's called flexor digiti minimi brevis, but there isn't a longus, so you can just say flexor digiti minimi. And you have the adductor hallucis. Remember, this is the one that has like the oblique and the transverse branch or whatever. And then the fourth layer is the interossi. So this goes through the first two layers. When we're talking about like the deep branch of like the lateral, it's going to go through the third and fourth layers. Makes sense. The deeper is going to go to the deeper layers. So she could give muscles like the deep branch will go between which two muscles, and it could be adductor hallucis and the interossi, because that's third and fourth layer. For first and second layer, she could say which muscles. It could be FDB and like the quadratus plantae, for example, or lumbricals. Okay, medial plantar artery. So it's going to pass along the medial aspect of the foot, and then it's going to go intermediate, so in between the abductor hallucis, so this thing right here, and the FDB, which are in the first layer, which we can see. The deep branch of it will go to the medial foot bones, and they're going to anastomose the plantar arch artery and the first plantar metatarsal artery. So this is the deep branch. So I'm going to go to the plantar arch, and that's going to go to the first plantar metatarsal. The superficial branch will have a medial part and a lateral part. So the medial part is going to go to the big toe. Lateral part is going to go to the arch itself. So lateral is going to go to the first, second, third, not fourth metatarsal arteries. The medial is the one that's going to give off the big toe thing, which is it's going medial to the big toe. So medial, it's on the plantar side. It's going to a digit, which is the toe, and that's proper because it's going to the phalanges. So medial, proper, plantar, digital artery. Lateral one, so lateral plantar artery, this is the larger one. Around the fifth metatarsal is where like you're kind of going to get the split. And then it'll have like a deep and a superficial. I don't think the superficial is on here, but the superficial is what gives off the little toe one. And the deep one's the one that's going to give off the plantar arterial arch. We said between the third and fourth layers. It goes dorsal, so like more up. If you're looking at like the foot, it's not the bottom of the foot, more like top of the foot, to the adductor hallucis, but it's going to be plantar under the interosseous muscles. And then the arch is going to give you your 4 metatarsal arteries. The first one is the one that anastomosis with the deep plantar artery, which I said is the one we're going to see that comes from the dorsalis pedis from the other side of the foot. So when the deep plantar artery joins the plantar arterial arch, that's what gives you like the first one, which is different than the other ones. So the second, third, and fourth do not get the plantar artery. Where's the lateral branch of the dorsalis pedis found? Deep to the EDB. I think they asked the same thing like earlier on. It was like, what's like deep to the EDB? And it was lateral branch of dorsalis pedis, which is the lateral tarsal artery, by the way. Then the key thing is it supplies the cuboid. All right, now on the dorsum. So dorsalis pedis comes up, or comes down. It's gonna give off lateral tarsal, so lateral tarsal bones, medial tarsal, medial to the tarsal bones. Okay. Then it's gonna give off this arcuate, so kind of like how in the back of the foot or bottom of the foot, you had the plantar arch that gave off the separate metatarsal ones. Here, same thing. The arcuate is gonna come off from dorsalis pedis, which this will give off the dorsal metatarsals. But the first one does not come from the arcuate artery. First one is actually one of the last branches. So this pink thing right here is still dorsalis pedis. So even after it gives off the arcuate, it's still dorsalis pedis. The 2 terminal branches are this first dorsal metatarsal, which is straight from dorsalis pedis, and then this dot going like down to the other side, the one that we said anastomosis to the opposite side, which is deep plantar. So these are the terminal branches. This green one to the big toe does not come from dorsalis pedis, not from DP. It actually comes from the first dorsal metatarsal, which this comes from DP. So I hope that makes sense. And that's pretty much everything that this does right here. Yes, so deep plantar terminal branch gives off this, but not directly from DP. And then dorsal metatarsals will split into like the digital ones, as you can see here. Okay, so first dorsal metatarsal comes from dorsalis pedis, but the other ones come from arcuate. And then first dorsal metatarsal will give you the medial proper dorsal digital whatever, which is this thing right here. And then the other ones will actually split into proper dorsal digitals, like we just saw right here. Okay, and then the medial one on the plantar side, so on the bottom of the foot, comes from the superficial of the medial. Lateral into the pinky toe comes from the superficial of the lateral. And then the other ones come from these, which comes from the plantar arch. And then only for the first one you get so it's the lateral plantar artery plus the deep plantar artery of the dorsalis pedis. That's what forms the first one, which is that thing we just talked about earlier, which is right here. And then I feel like she had this as like one of the accept things, is that it passes deep to the DTMO. Okay. Anastomosis between the dorsal and plantar arteries. So as we can see, obviously they connect. Oh, we saw one of the examples of them connecting, which was the deep plantar artery through the first metatarsal space to go to the back, which is the plantar arch. You also have proximal perforating arteries that connect the plantar, so bottom of the foot metatarsal arteries, to the dorsal near the bases. So proximal is going to be near the bases. Distal is going to be near the heads, which makes sense. The heads are farther down or distally. And then if the dorsalis pedis is blocked, you can still get blood supply from the lateral plantar artery, which is the artery on the bottom, because we have the plantar arterial arch, which we talked about in anastomosis. And then you also have the perforating arteries, which in anastomosis. And sometimes you can get like the fibular artery goes down and it has perforating branches and everything in anastomosis. So you're not going to die, hopefully. Okay. I am exhausted. All right. Marginal veins. So you have this dorsal venous arch right here. So this dorsal venous arch, now we're talking about blood going up. So with arteries, blood was coming down. With veins, blood's coming up. So dorsal venous arch. Eventually, as it goes higher up, medially it's going to be medial marginal vein. Laterally is going to be lateral marginal vein. And then laterally will become small saphenous vein. Medially will become greater saphenous vein. Great saphenous vein is going to go anterior to the medial malleolus because it's going to go all the way up the medial leg and thigh, drain into the femoral vein. Small saphenous vein is going to go posterior to the lateral malleolus because it's going to the back of the leg and draining in the back of the knee into the popliteal vein. Now, this doesn't like officially become the medial marginal vein until the big toe medial proper dorsal digital vein joins this arch. When that happens, this becomes medial marginal. And then same thing on the side. When the pinky one joins the arch, now it becomes lateral. So that's like the key thing right here. So lateral side of dorsal digital vein of little toe joins dorsal arch, becomes lateral marginal. Medial blah 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 of the helix joins dorsal arch, becomes medial marginal. And then they become great and small saphenous. So medial becomes great, lateral becomes small. Now on the medial side, the nerve that it travels with is the saphenous nerve. On the lateral side, there's like so the sural nerve, remember how we said it goes to the back of the leg, it formed from the medial and communicating sural, which came from tibial and common fibular, and then goes back to the leg, but it ends on the lateral side. So the lateral marginal vein actually runs with it. But if they ask what nerve runs with the great saphenous, so here we're talking about the marginal veins. So medial marginal is saphenous, lateral marginal is lateral dorsal cutaneous, which is a branch of sural. But if they ask about great saphenous vein, the nerve that runs with it is saphenous nerve. Remember, in the leg, if it was in the thigh, it would be medial femoral cutaneous, whatever. For the small saphenous vein, it's the sural nerve. Functional anatomical joints. So remember, anatomical joints are just like, it's the joint between the two bones, just like the connection between them. So you're not talking about the entire joint itself. When we're talking about the functional subtalar joint, we're talking about everything between those two bones that allows this joint to have a function or to move. When we're talking about anatomical, we don't care about the movement in the entire joint. We just want to know specifically what's between these two bones. So the subtalar joint, the functional is going to do like inversion, eversion. For the mid-tarsal joint, this is the CHO part. So it parts the tarsals. So you're separating the calcaneus and talus from like navicular and cuboid and the rest of the tarsals because you have your cuneiforms here. So that's CHO part. But what separates the tarsals from the metatarsals is Lisfranc. The way I remember it is Lisfranc sounds like a girl and a guy name. So you're separating two different things. So here you're separating tarsals and metatarsals. You're separating two different things. Chopart, you're just parting the tarsals. So these are all tarsals, you're just cutting them in half. Then the anatomical are just the names themselves. So talocalcaneal is the anatomical subtalar joint, just between the talus and calcaneus. Up to, or the most anterior is going to be the sinus tarsi. You don't go farther than that. Whereas the functional subtalar joint, you would do everything in there, including the anterior side. Then you have the talocalcaneal navicular, so spring, calcaneocuboid, cuboid to the metatarsals, so fourth and fifth. Remember, fourth is the quadrangular shape, fifth is the lateral apex triangle. Medial tarsal metatarsal is the first one. So this is going to be the kidney shape between the medial cuneiform and first met. Great tarsal is like all of like the tarsal stuff, not including the calcaneus and talus. So it connects the cuneiforms to each other, what connects them to the cuboid, what connects them to the navicular, all this stuff, whatever. The 5 MTP joints between each one. Then remember, we have only 9 interphalangeal joints because the big toe only has 1 interphalangeal. Everything about the MPJ and IPJ. So she said everything. I think this is probably like an accept question. But, I mean, there were a lot of slides on this stuff. But the main stuff that she said before, stuff she's asked, we already said how, like, for the dorsal tubercles, they're on everything except the distal phalanx. The sesamoids and crista create like a pulley system. She had that as a question before. The crista does not have any muscles that attaches to it was another question. What else? Difference between them is that the MPJ, so metatarsophalangeal joints, so they're both synovial, but this is going to be condyloid, whereas this is hinge. She definitely asked about the hinge one. That might have been a lab question. I think it was. But the MPJ are biaxial. This is uniaxial. Then you have 5 of them, whereas here you have 9 because only 1 in the big toe. Only the first MPJ contains sesamoid bones, so she could definitely ask that. The plantar plate resists hyperextension. This was in like the Ohio notes as well. DTML. Oh, shit. Let's move it this way. Okay. DTML is only between the 2nd to 5th MPJs. Remember, it runs from like lateral to the 1st, like medial to the 5th or whatever. Your pads and dabs. D is going to dorsal abduct. Plantar is going to adduct. Lumbricals, we said flex the MPJ, extend the IPJ. The IPJs are only going to do flexion and extension, because remember, they're uniaxial. Whereas MPJs are going to do flexion and extension, but they'll also do abduction, adduction, and some circumduction. So in other words, the MPJs can move much more than the IPJs. All right, this was like the earlier stuff. Knowing the nerve roots for the lumbosacral plexus. So this picture really does a good job of like combining them. We talked about how like femoral is going to be L2 to L4. Obturator is also L2 to L4, but it's more like medial. This is more like lateral to the psoas major. You can also see here why the obturator one is more like ventral, whereas the femoral one's more dorsal, because this is going like back, this is going front. So these are all the nerve roots. These are like the main ones. LFC is missing the 4 from femoral. And then remember, if you remember, it's ILI. I remember like IL1. So the ilios are L1. LFC is like 1 lower than the genitofemoral. Inferior gluteal takes 1 lower. So instead of 4-5-S1, it's 5-S1-S2. PFC she's asked about like twice before. So knowing that it's S1, S2, S3. Knowing that it does like sensation to the back of the thigh. Oh, we already talked about the sciatic ones. Pudendal, remember it's like S2, S3, S4 keeps like the poo off the floor, because that like will make sure that like your external anal sphincter is like closed. If you can't control that, you'll just start, you know, everywhere. We already said this, between ventral and dorsal rami. Anterior means ventral. Posterior means dorsal. I think we already did all those. Yep, F's in the back, dorsal, ventral. Sensory innervation, the one she's asked before is, she was like, all of the following do like sensation to the back of the leg except, and the answer was superficial fibular. Because you can see on the back of the leg, you have like the PFC in green, you have like the saphenous here, you have the common fibular, you have like the sural, but not superficial fibular. This picture does a good job of showing that. So lateral thigh, LFC. Superficial fibular is going to do almost all the dorsum of the foot, except this swept space right here, which is going to be deep fibular. Lymphatic drainage, the thing she's asked before was either like horizontal goes along emetal ligament, or the one she loves is that the vertical lymph nodes go around the great saphenous vein, because great saphenous runs like this, whereas emetal ligament runs like this, so it makes sense that the horizontal lymph nodes, vertical lymph nodes follow that route. Superficial is going to be, when we're talking about superficial lymph nodes, you're talking about like great saphenous, small saphenous, deep's going to be like femoral, popliteal, and then we said this, small into popliteus. I hope we know everything about the great saphenous. She asked the question about like if you have like varicose veins or varicosities along like the great saphenous vein, where do you not see changes? And it's the posterior leg, because posterior leg is small saphenous, not great saphenous. We already talked about the lateral margin becoming small saphenous, medial great, whatever. The septa on the leg, so for the thigh, the lateral is going to separate anterior posterior, medial is going to do anterior medial, but posterior is going to do medial and posterior. So knowing that medial separates anterior and medial, so the one in the back will separate medial posterior. For the leg, it makes more sense. Anterior is going to separate anterior lateral, posterior is going to separate posterior lateral. Interosseous connects the tibia to the fibula, so it's going to separate the anterior to deep. So it separates both posterior compartments. It's what separates the anterior compartment from the deep posterior. So you have anterior compartment, lateral compartment, and then posterior, but you have a superficial posterior and deep posterior. So interosseous separates anterior to deep posterior. Anterior will separate anterior from lateral. Posterior will separate posterior from lateral, but what separates the deep posterior and superficial posterior is the deep transverse septum, which is what she's asked multiple times. And then knowing the different types of joints, I feel like she's going to ask, is going to be that like the distal tibiofibular, which is the syndesmosis between the tibia and fibula, is a fibrous joint, whereas the proximal is a plain synovial joint. If she asks the cartilaginous, and pubic symphysis. So fibrous, they're connected by dense fibrous connective tissue. Cartilaginous by hyaline cartilage or fibrocartilage. And the synovial, the bones are connected by a fluid-filled cavity. So like in the hip joint, it's a ball and socket. But like, you can all have a different synovial joint, which isn't ball and socket, but it's a plain synovial. For the movements, it's just memorizing these. The one she's asked before is the flexion at the hip, which is L2, L3. And these are some questions that she asked that I didn't know where to fit, or I remembered after. So if a patient has right-sided butt claudication, so you lose blood flow there, and weak right-sided femoral pulse, where is the block? It's not the right femoral artery, because it's not just the femoral pulse, but it's also the butt stuff. So it's right common iliac artery, because that's going to split into internal and external iliac. External is going to do the femoral stuff. Internal is going to do the stuff. If you're sitting in a chair, the muscle that eccentrically contracts to control flexion. So eccentrically is the thing doing like the opposite, right? Because if I flex my arm, like you're curling, your biceps concentrically contract because they're shortening, but your triceps are doing the opposite, so they're eccentrically contracting. So here, if you're sitting in a chair, your hip you're bending, you're flexing your hip. So the thing that does the opposite is your quads, which would extend your knee. They've asked about corona mortis before. It's the accessory obturator artery that you damage during surgery. Accessory obturator comes from inferior epigastric, which comes from external iliac, if they ask. The IT band has two muscles that form the IT band. It's the tensor fascia lata and the gluteus maximus. She asked, like, what nerves innervate the muscles that join to make the IT band. So superior gluteal innervates TFL, inferior gluteal innervates gluteus maximus, and then these are the ones that form to join the IT band. That was like a 17th order question. If she asks what goes through the adductor canal, but not the hiatus, it's the saphenous nerve and nerve to vastus medialis. If she asks what goes through both, it's the femoral artery and vein. She had a question like increased Q angle, what could that damage? And that's the patellofemoral. It causes like patellofemoral degeneration because the knee's bent too much. Like your knees are touching because it's an increased Q angle. If it was a decreased Q angle, your like medial malleoli would be touching. But if your knees are touching, that's like the Disney knees. I don't know why I love this example. But like, obviously that wouldn't be stable for the knee. Remember, Haglund's deformity is the PSL, posterior, superior, lateral calcaneus, that could damage the retrocalcaneal bursa, and it could damage the Achilles tendon. The crista, remember, no muscles attached there. The highest point of the medial longitudinal arch, oh, we have to go over this right now, is the talar head. Now, let's go over the arches. Before that, really quickly, she had a random question. It was like, which part of like the leg bones is smooth and has no attachments? The medial tibia. You can like feel it on yourself. It's so smooth. Okay. Medial longitudinal arch, we're talking about the stuff on the medial side of the bottom of the foot. So calcaneus, talus, navicular. The cuneiforms because they connect to your navicular, and then the first to third mets because they connect to your cuneiform. So if you remember, these connect to this, which connects to this, and then calcaneus and talus because that's the medial side. Lateral also gets calcaneus, so she could be like, which of these are in both the medial and lateral? It's calcaneus. Lateral is just the other side, so you get the calcaneus, but now instead of navicular, you get cuboid. Then instead of first to third mets, you get fourth to fifth mets. No cuneiforms because fourth to fifth connect straight to cuboid. The transverse arch, which is the bottom, you have cuboid, cuneiforms, and then the bases are like the beginning of all five mets. So she could ask which bone is both in the lateral and transverse, and it's cuboid. Difference between hindfoot, midfoot, and forefoot. So hindfoot, we're talking about the back, so calcaneus and talus. Midfoot is like the middle, so it's like the rest of the tarsal, so navicular, cuboid, and the three cuneiforms. Forefoot is all the metatarsals and phalanges. She had a question, it was like, the forefoot consists, and it was metatarsals and phalanges. The Achilles tendon, know that there is no synovial sheath. It has something called a peritoneum, so not a synovial sheath. Know that the lateral cuneiform connects to 6 bones and 3 metatarsals. So you have lateral cuneiform, which connects to intermediate cuneiform, cuboid, navicular, and third met. However, the second and fourth mets also hit like the corner of the lateral cuneiforms. So you think these are like the 4 main ones, but it also gets these 2. So it gets 6 total bones. And she had another question, how many metatarsals? It's not just 1 metatarsal, it's actually 3 metatarsals, which is kind of messed up because if you got the first one wrong, you're going to get the second one wrong, but whatever. Which muscle goes through the sulcus of the cuboid? Fibularis longus. Know that for the fibular trochlea, the fibularis brevis goes superior to it, fibularis longus goes inferior to it. Remember the fibularis brevis attaches at the tuberosity of 5th met. The longest is the one that goes like under, and then it goes like under the foot, goes to like the bottom of like the first met / medial cuneiform location, whatever. No, for snowboarders fracture, it's the lateral talar process that's fractured, and that's due to inversion, dorsiflexion. Also like axial loading, which is like when you're downward, like striking your leg. This was a weird question, but it was just like knowing your locations. So compared to the the medial cuneiform is like in front of it, so it's anterior to it, or you can say distal to it, so farther down, or anterior to it. If it was behind it would have been proximal or posterior. And the deep transverse intermuscular septum, we said separates the posterior leg compartments, so it's the posterior superficial and deep, posterior superficial and deep superficial, deep, posterior superficial and posterior deep compartments. Which is like, remember, superficial is like gastrosoleus, plantaris, deep is like the tibialis posterior and all the other stuff. And then if she asked the degrees question, she had a question that was like between like the first 2 mets or something. Usually it's like 0 to 8 degrees, and then something about the arch for the talar head, and it was 24 degrees. Sorry guys, I got like really exhausted at the end. Love you guys. The last part, which is like the 10 slides, I forgot to include them in here, and this kind of went a little too long. The 10 slides on like the common exam 3 questions that were wrong, definitely review that, and I hope this helped.